Right. Good afternoon, everyone. Thanks for joining our community health webinar for this month. I'm going to go ahead and get started with some introductions and just some housekeeping items. And then we're going to dive in and pass it over to our presenters for today's webinar. To get started, I just want to let everyone know that your videos and microphones are disabled. So you are welcome to use the chat to introduce yourself if you'd like. That is also where you can ask any questions throughout the webinar. And then there's also a Q&A feature at the bottom of your screens. There's a little Q&A button. You are able to ask questions with that as well. The Q&A is an anonymous option for asking questions. And we will be checking those and going through both the Q&A and the chat towards the end of the webinar. And then if you do really have a question that you would like to ask verbally, you are able to raise your hand with the raise hand feature also at the bottom of your screen. And I can unmute you for your question again at the end of the webinar. So we're going to dive in and get going with our presentation after I get back to the beginning of the page. Okay. So today we have with us Jacobi, Jarski, Gwendolyn Davis, and Valborg Kvigne with the MHA or the Fort Berthold Diabetes Program at MHA Nation to go over how mobile life imaging identifies participants with risk factors for cardiovascular disease and their mobile health imaging unit. So without further ado, I am going to pass it over to our presenters to get going today. Thank you for being with us.
Good afternoon, everyone. My name is Jacobi Jarski. I'm our Good Health and Wellness in Indian Country Grant Manager for the Fort Berthold Diabetes Program, and I've been with the program a little over 2 years now. Presenting alongside Gwendolyn and Valborg. Glad everyone was able to join us today. Slide. We would like to acknowledge all of the staff that have worked on the project throughout the grant's life and thank them for their help in making our events successful. The objectives of today's presentation are to describe the benefits of checking cardiovascular health using the mobile health unit for rural areas, describe the mobile life imaging results for the testing that they do, which is carotid stroke and carotid artery disease, abdominal aortic aneurysm, peripheral artery disease, and arterial stiffness index, and describe the referral process for follow-up with the participants who have been identified to have increased cardiovascular risk factors. The Fort Berthold Diabetes Program is managed by the Mandan Hidatsa Arteria Nation. We're located right across the parking lot from our medical center here in Newtown, North Dakota. A few things that we have to offer here at the diabetes program: we have an indoor walking track, our fitness center, a 12-station teaching kitchen, 4 clinic rooms, a physical therapy room, and 1 classroom. The 3 affiliated tribes, which is home to the Mandan Hidatsa Arteria Nation, is located on the Fort Berthold Reservation in western North Dakota. The approximate population of the reservation itself is approximately 7,500 people. Our reservation consists of 988,000 acres of land on both the east and west side of the Missouri River. With only 1 bridge crossing the Missouri River, driving distance to the central hub community in Newtown is very extensive, with the farthest community being 100 miles one way. The Fort Berthold Reservation, located in western North Dakota, is one of 5 reservations in the state of North Dakota. And we're located along the Missouri River and Lake Sakakawea. Our reservation consists of 6 communities spreading across 5 towns, with many of our residents living in very rural areas. According to data from 2021, the 3 leading causes of death in both North Dakota and South Dakota are heart disease, cancer, and COVID-19, with heart disease leading in North Dakota and cancer in South Dakota. Our central hub is in Newtown, the closest ER with a trauma center that is able to handle cardiac events is 70 miles one way. And our location, which is in the middle of the Bakken oil field, is very, very high truck traffic, and that does affect the ability for ambulances to get where they need to get. With most of our community members living so rural, the ambulance isn't able to get them to the ER within that 60-minute window for better patient outcome. The availability for Mobile Life is very crucial for our rural community members, because it's able to help them identify those cardiovascular risk factors before an emergency. So they're able to have those preventative measures taken. We have offered our Mobile Life imaging services in each community to make it more accessible to community members who aren't necessarily able to travel to Newtown as often. So our methods of recruiting participants: we post flyers in our communities that we're offering the events in. We use our social media, and then we also advertise in local newspapers, and flyers are also posted in our local healthcare facilities. The diabetes registry is also used to identify participants, and that is done with the parameters of 30 years and older, diagnosed hypertension, and diagnosed elevated blood cholesterol. Those participants are then reached out to and invited to come participate in our event. Recruitment is also done through our tribal and clinic employee emails, and we also work with our primary care physicians in the main clinic and in our field clinics to refer patients. We've also had quite a few patients who have self-referred because they knew somebody who took advantage of being able to attend one of our events and thought that that would be a good idea for themselves as well. Our wonderful medical support assistants are the ones who do a majority of the recruiting. They're the ones who call the participants and schedule them for the Mobile Life imaging. Then multiple calls are made after the fact, reminding patients of their appointments. And usually it's between 2 and 5 or 6 phone calls or text messages that are sent to remind patients of their appointments and make any rescheduling if necessary. We also have a wait list that is used in the event of a cancellation. So we have a short call list. So those who would like to take advantage of this opportunity are able to if we have cancellations. Mobile Life Imaging is based in Fargo, North Dakota. It's usually 3 to 5 months in advance that we schedule with with their office to make sure that we're able to get our dates scheduled. Depending on the population of the community and how many patients we plan on serving in that particular community, our imaging events are scheduled between 2 and 4 days. We also have multiple education and screening stations that are set up as well with the mobile life imaging. The imaging itself takes approximately 45 minutes to an hour, and our goal is 20 participants per day.
Hello, everyone. My name is Gwen. I am the director and the nurse for the Fort Berthold Diabetes Program. So for this slide, it goes over the flow of the actual Mobile Life event. The participant starts by checking in with the diabetes program staff at the registration table. The participant then moves on to the screening that is performed by the diabetes program staff. This includes blood pressure, BMI, height and weight, the hemoglobin A1C, a random glucose, a pulse, as well as a total cholesterol. The participant then moves on to the next station and meets with either our clinical registered dietitian or our community registered dietitian. And then they round out with meeting with the Mobile Life imaging team. This last Mobile Life imaging event, we did add in our JVN retinopathy screening. So that was a good addition, as myself and our community dietitian are able to perform that screening. So that was a good addition. Okay, and so the participants meet with one of our registered dietitians who provide nutrition education. It's usually about a 10-minute or so consultation. They explain the health screening results of blood pressure, BMI, the hemoglobin A1C, the random glucose, and total cholesterol in correlation with their diet. And then they describe these foods that are associated in their health benefits. And then something that they try to do is to encourage participation in our monthly cooking classes. So our dietitians hold 2 classes every month. And then incentive-wise, we give each participant usually an insulated grocery bag, some Mrs. Dash salt-free seasoning, as well as a heart healthy cookbook. Okay, and then Mobile Life imaging data collection includes assessment of 4 key indicators that may contribute to adverse cardiovascular events. This assessment is done primarily using ultrasound technology that can detect fatty deposits, also known as plaque, that can block blood vessels and lead to carotid artery disease, along with stiffening or narrowing of the arteries, resulting in peripheral artery disease. Abdominal aortic aneurysms appear as a bulge or balloon where the artery has weakened. Result values that warrant follow-up are those with moderate to severe narrowing of the arteries, or those with large amounts of plaque buildup that could affect blood flow. Any size aortic aneurysm is referred to the healthcare provider immediately. Those participants who have abnormal ankle brachial or arterial stiffness indexes are referred as well. So before Valborg dives into the data portion of the presentation, I will define some of the terms that you may hear as she is presenting. A body mass index, or BMI, is calculated using a participant's height and weight. A healthy BMI is between 18.5 and 24.99. I would like to specifically point out that class 1 obesity ranges from 30 to 34.99, and class 2 obesity is 35 to 39.99. The farther participants remain from a healthy BMI, it is more likely that chronic diseases such as diabetes and cardiovascular disease will develop. Moving on to the hemoglobin A1C, or HbA1c, is defined as an average blood glucose level over the previous 2 to 3 month period. An A1C of 5.7 to 6.4 indicates that a participant has pre-diabetes. Diabetes is usually diagnosed with an A1C that is equal to or greater than 6.5. All data is entered into the participant's electronic health record to give their primary care provider access to the results. And then our project funding comes from the Good Health and Wellness in Indian Country grant, which is provided through the Centers for Disease Control and Prevention. All right, Val?
Thank you, Gwen. Well, I've had the pleasure of working with the Fort Berthold Diabetes Program in evaluation, and we'd like to share some of the results with you today. The results will be preliminary since the program continues to collect mobile life imaging data. So the data that will be relate between July 2020 and July 2023. That's the time period when these data were collected. And they were collected for 6 mobile life events in 4 different communities. The program had approximately 400 participants, of which approximately 4% of the participants with cardiovascular risk factors were referred for follow-up with their primary healthcare provider. So we did a 2-tailed t-test to determine, is there a difference between the participants who were not referred compared to the participants who were referred. And since we had a small percent of participants that were referred for follow-up, that statistical cautions can be the results, and p-values can be exacerbated or they can be missed. However, we did have statistical results identifying variables that contributed to a referral for cardiovascular disease. The p-values less than or equal to 0.05 were considered to be statistically significant. When we looked at the participants who participated, approximately 40% of the participants were males and 60% were females. And then for the participants who were referred, approximately 38% were males and approximately 62% were female. As Jacobi mentioned, we did have some participants who self-referred. So we did have some people in the 18 to 24 years, just a very small percent there. We also had some participants from 25 to 44 years, approximately 16%. The majority of the participants were 45 years and older. And of the participants who were referred, they were all 45 years and older, with the greatest percent being with the older age of greater than or equal to 61 years. Now, when we talk about the referral, Gwen mentioned participants were referred on carotid artery, aneurysm, peripheral artery disease, or arterial stiffness. That's what triggered the referral. Gwen also reviewed all the screening variables that they collected when they did these mobile life events. And what the purpose of these variables is to define or identify variables that can help us identify people most at risk for having cardiovascular risk factors. And the A1C turned out to be very significant. Now, the mean A1C for the participants who were not referred was approximately 7, whereas the mean A1C level for participants who were referred was approximately 9. So participants that have probably a 9 or higher are at greater risk for being referred for a cardio risk factor. Now, if you're doing community screenings and you do not have A1Cs, or you do not know someone's A1C, a random blood glucose will work just as well. The mean random blood glucose, which is just the average, was approximately 135 milligrams per deciliter, and the mean random blood glucose for participants who were referred was 220. So you can see any participant with an elevated random blood glucose is at a higher risk. So this is important information to consider when you're looking for cardiovascular risk factors. Now, weight was also significant, but it went in the opposite direction. So the participants who were not referred had a weight of approximately 220 for an average, but the participants who were referred had a weight of approximately 180 pounds. Along with the pounds, the BMIs corresponded to the weights. So the people who were referred were more likely to be in class 1 obesity, whereas the participants who were not referred were more likely to have class 2 obesity. Now, how can this be? Well, let's drop down to the bottom row, and we'll see that the participants who were referred, the average age for these participants was approximately 62. And the average age for participants who were not referred was approximately 56. So people who are older generally have they don't eat as much food, they don't have a need for more calories, and so consequently, by eating less and probably a little bit more physically active, so they're not needing more calories, they are more likely to weigh less. So the age was also statistically significant. Another variable that was significant was the diagnosis of diabetes. Now, it can be any diagnosis, if it's prediabetes, type 1, or type 2. We see that the mean participants for participants who had a diagnosis of diabetes was approximately 57%, and approximately 88% for the participants who were referred. So diabetes is a significant factor in identifying people with greater risk for cardiovascular or heart disease. Now, the variables that were not statistically significant, the first one is blood pressure. Systolic came the closest at 0.08. The mean systolic for participants who were not referred was approximately 140, compared to approximately 150 for participants who were referred. Now, the diastolic was not significant. Height was not significant. Pulse was not significant. And total blood cholesterol was definitely not significant. The mean total blood cholesterol for participants who were not referred was approximately 183, whereas the mean for participants who were referred was approximately 180. So this is in very normal range for looking at total blood cholesterol. Now, as Jacobi mentioned, the whole process of recruiting people started out with blood pressure, elevated blood pressure, and elevated total blood cholesterol. However, we didn't find that. Total blood cholesterol is not significant. So this is why it's so important to collect the data that you're, or to record your data, have it in a system that you can have it analyzed So you can use these data to help you reach the population that really needs your interventions. The percent of males that were not referred compared to males that were referred, neither the males nor the females were statistically significant.
All right, so I'm going to go over a little bit about the follow-up process to notify patients of their results and such. So all participants receive a letter along with their mobile life imaging results. And as stated before, their screening result sheet is uploaded into their electronic health record so that their providers can review that. Or if for some reason the mail fails us and they don't receive the results or something like that. So the registered nurse and grant manager review the mobile life imaging results and determine which participants need to be referred for follow-up. Abnormal results are faxed to the primary care provider, and a call is made by the RN to the primary care provider to let them know of the abnormal results and to let them know that the fax is being sent. The medical clinics contact the referred patients to schedule them for follow-up. So 100% of referred patients completed a follow-up visit with their healthcare provider. So that is something important to note. And then one of the successes of the mobile life imaging has been helping to quickly identify a participant who had a rather large aneurysm that required them to go into immediate surgery. So that was a really big success. And we have been able to identify a few other aneurysms since then. And then just with the health screening part that the diabetes program does, we've been able to identify participants who were, say, unaware of their some severe undiagnosed hypertension or elevated A1Cs. So then we can get them over to their provider for a follow-up visit just to get that taken care of. So overall, you know, with the health screenings and then the nutrition and the mobile life piece, it's just a great overall, you know, program to get those patients in with their provider.
So in conclusion, the mobile life imaging has contributed to extending participants' lives, as Gwen pointed out. Community members view the mobile life imaging as a valuable resource with a 100% of the participants referred completing follow-up visits. That's basically unheard of in healthcare. It's to get a high percentage of people completing follow-up visits is commendable. And these data also suggest changing the target group to include individuals with elevated A1C or random blood glucose levels, in addition to elevated blood pressure. And as a result of the program, looking at these individuals more closely and recruiting from a group of people that have elevated A1Cs or elevated random blood glucose, it's resulted in additional referrals. So we thank you for your participation, and we welcome any questions.
Absolutely. Thank you so much, Valborg, Gwen, and Jacobi. I agree that 100% of referred patients completing their follow-ups is amazing. Congratulations on that. That is awesome news. I'm going to stop sharing this screen. Yeah, so we're going to open it up for questions. Like I mentioned before, you can type your questions in the chat. There's also the Q&A feature at the bottom of your screen if you prefer asking a question that way. I'm not seeing any questions at the moment in either of those, but I was going to ask a quick question while we're waiting. As far as recruitment, of participants for your mobile life imaging unit. What have you kind of discovered works best? I mean, do you just set up all on your own and advertise that you're coming to the communities, or do you kind of partner up with other activities already happening, or what have you kind of discovered gets the most participation when you travel?
So when we recruit participants, the list that Gwen is able to pull from the diabetes registry is usually where we find a majority, if not all, of our participants. We also work with the providers in our field clinics when we are going out into the outlying communities on a referral basis. If they have patients that they see that they feel would benefit from the services that we're able to offer them, then we get them scheduled for mobile life imaging. But for the most part, it's the list that Gwen is able to pull from the diabetes registry with the parameters that we've discussed.
Yep, and then we're gonna have a heart healthy event here in February, and we're gonna try that out, recruiting patients at that. Jacobi will try to get, some people that haven't been screened in the past to sign up there. So hopefully that'll be successful too.
Gwen or Jacobi, do you want to talk a little bit about word of mouth?
Yes, participants who have done the event prior to our current events going on right now are very vocal when it comes to spreading the word about getting people in and getting them scheduled. Our participants are very, very helpful when it comes to spreading the word and referring friends and family members to get a hold of us to get scheduled. So our community is very, very close-knit. And when one person likes the services that they're receiving, they're going to spread the word. So we're very lucky that our community members are also helping us in that aspect.
That's great. I love to hear that. Okay, I'm not seeing any other questions from anyone else. As a reminder, this webinar has been recorded, and we will be sending out a follow-up email to everyone who has registered today. So if you ever want to go back and look at anything, you will have access to that recording. I am going to put a link to a short evaluation form in the chat. We appreciate everyone's feedback and help with future webinars. So if you could please take a quick second to fill that out, we appreciate it. Otherwise, if there are no other questions coming in, which I don't see, we'll go ahead and end our webinar today. Again, I want to say a big thank you to our presenters, Valborg, Gwen, and Jacobi, and our fellow GHWIC participants. So we are so glad to hear of all the wonderful work that you're doing over in Fort Berthold. So thanks for hopping on and sharing all of your wonderful success with us. And we hope everyone has a good rest of your day and rest of your week. Thanks, everyone.